Good afternoon to all our summary audience. Thank you for having me today. First, I would like to acknowledge that I am presenting a project that was developed here in the lands of the Ghana people. So I would like to pay my respects to their elders, their past, present, and emerging generations and leadership. Personally, I would love to see an Australia that recognizes and includes First Nation people and their knowledge in every practice and every aspect of our society. As the program indicates, I am presenting today about CROW, what we call cardiac rehabilitation for all. This work was led and is led by Dr. Aline Beleigoli, and it was co-developed by a big team of fantastic co-authors who passionately work on the project and the results that I am presenting to you today. We call this project Cardiac Rehabilitation Utilization, its clinical effectiveness, and barriers to completion among patients of low socioeconomic status living in rural areas of Australia. This study is a mixed methods study. So we know the cardiac rehabilitation significantly improved capacity and reduced traditional cardiovascular risk post-discharge. However, the utilization of cardiac rehabilitation programs remains low globally, particularly among patients with low socioeconomic backgrounds. People with socioeconomic disadvantages, principally those living in rural areas, have higher risk of cardiovascular events. Their cardiovascular death rate is higher for both males and females when compared with high socioeconomic status people and areas. In low socioeconomic areas, psychosocial stressors for economic instability, limitations in neighborhood-built environments, education, healthcare access, and social relationships contribute to the increase of cardiovascular risk. These issues are more prominent in rural areas than metropolitan areas, as socioeconomic status is typically lower for such locations. So patients from low-income areas, including those living in rural areas, are less likely to attend or complete cardiac rehabilitation programs. These situations and characteristics highlight the necessity to investigate and to address these and other barriers to completion and understand the specific needs of these particular populations. So considering the background that I just presented, we aim to understand cardiac rehabilitation and its effects on hospitalizations and mortality amongst 16,159 hospital admissions of patients with low socioeconomic status here living in rural Australia. The study involved all South Australian hospitals, public hospitals, and 15 public cardiac rehabilitation programs in rural areas. These cardiac rehabilitation programs included core components such as referrals and access to services, clinical assessment, recovery and long-term maintenance, lifestyle and behavior modifications, and evaluation and quality improvement. The study employed a concurrent triangulation mixed method design. This means combining a retrospective cohort study and a qualitative study. So the quantitative component assessed the cardiac rehabilitation utilization and clinical effectiveness by linking clinical and administrative data sets. And the qualitative component involved conducting semi-structured interviews and focus groups with 28 participants to explore the barriers and needs related to cardiac rehabilitation completion. So the third component is basically what allows us to complete the triangulation, which is the convergence of these results from both quantitative and qualitative data sources. So following that methodology, we found that only 11.2% of the eligible patients completed their program. But we also identified that completing their program reduced the risk of hospitalization and mortality. In reference to the barriers, we identified that being old, living alone, or having diabetes or depression and being enrolled on the telephone program compared to the face-to-face program increases the risk of non-completion, whereas being enrolled in a telehealth program decreases the risk. Participants refer to better logistics, social support, better transition of care, and its integration with a person-centered approach as enabler factors to cardiac rehabilitation completion. These findings can be used to co-create and inform the development of programs that better match the needs of people living with socioeconomic disadvantages, or living in rural and remote regions of Australia. Okay, so after those results, I'm going to share the main insights that we gain from this study. So first, living alone and having low social support were associated with higher risk of non-completion for cardiac rehabilitation. Participants in the qualitative study highlighted the need for social support for those living alone. Early identification of patients living alone and providing social support, including home visits, can increase the participation in cardiac rehabilitation. So poor transition of care from hospitals to the start of the cardiac rehabilitation, including long waiting times, a lack of clear communication, contributed as well to patient lacks of interest and non-completion of cardiac rehabilitation. So we need to improve the transition of care quality, reducing waiting times and enhancing communication. This can augment patient interest and participation in cardiac rehabilitation. Additionally, health literacy played a very important role in patients' perceptions of not being interested or seeing less value in the process of cardiac rehabilitation. So cardiac rehabilitation programs should consider a variety of approaches to meet the diverse health literacy requirements and provide sufficient informational support for patients. Lack of integration among multiple care providers during the cardiac rehabilitation process was something that was mentioned by participants, including the general practitioners, the GPs, affected patient engagement in the participation. So ensuring information, sharing information, more integration between the patients, outpatients cardiac rehabilitation programs and primary care providers such as the GP is crucial to increase patient confidence and participation in cardiac rehabilitation. So cardiac rehabilitation delivered via telehealth show potential in improving care integration and increasing cardiac rehabilitation completion. Telehealth reduced logistic barriers and allowed for individual sessions addressing concerns such as distance, travel, group sessions attendance that we observe. However, challenges related to mental health support, exercise safety, and a lack of peer support opportunity were also identified in our study. Telehealth services need to be redesigned to meet the specific needs of patients at high risk of non-attendance. So tailoring cardiac rehabilitation components, including mental health, support, and exercise intervention, is crucial for individuals with diabetes, depression, and other comorbidities. Personalization is key. So offering alternative forms of exercise can improve cardiac rehabilitation adherence and participation, particularly among women with diabetes. So these main insights point towards the importance of social support, effective transition of care, health literacy, care integration, telehealth personalization in enhancing cardiac rehabilitation participation and completion among individuals with low socioeconomic status living in Australia rural areas. In conclusion, by investigating cardiac rehabilitation utilization, its clinical effectiveness, and barriers to completion among patients with low socioeconomic status living in rural areas of Australia, we have identified that cardiac rehabilitation completion was low, but it was essential for reducing mortality and hospital readmissions. Our findings highlight the importance of social support, a better transition of care, health literacy, care integration, telehealth, and personalization in enhancing cardiac rehabilitation participation and completion among individuals with low socioeconomic status living in rural areas of Australia. Thank you so much for paying attention to our study and our results. We aim to utilize these findings and other set of findings from different studies to together codify and co-create and implement better healthcare services for all Australians.